welcome again to another session in Transforming Digital Health series, sponsored by Bouvet and Health Sciences Entrepreneurs here at Northeastern University. My name is Danny Kim. I'm Doctor of Pharmacy student here at Northeastern. And outside school, I'm also the head of corporate development at Wealth. We're a spin-off of Samsung that's making digital biomarkers and digital therapeutics. We've been organizing the Transforming Digital Health series to give a kind of front seat view to you in the audience of what it's like to build and invest and at a higher level make policies around digital health. In the previous couple of sessions, we talked about what digital health is, specific use cases like digital therapeutics, and what goes behind making of a rockstar digital health products and services from an investor and operator. So today we have Robert Longyear, VP of Digital Health and Innovation at Avenue Health and author of Innovating for Wellness. I'll definitely leave the detailed intro of what Robert's kind of journey has been like in healthcare, but just to give you a little more background in terms of the topic that we are discussing today. Although I cannot promise that we won't go side topic with all the exciting experience that Robert had, but we're talking about chronic disease management. And chronic disease management probably is one of the best kind of use cases that we've been seeing digital health kind of playing a part in. And, I think it has to do a lot with how digital health can also kind of be referred to as data-driven healthcare, in the sense that, if there's one advantage of digital health is our ability to collect, analyze, integrate, and to treat with data. And, this kind of having the data and being able to use it for the continuous monitoring and also care for a patient and creating the continuum of care, whether that be in clinic or at home, I think has been a tremendous kind of value add in this space. So without a further ado, I'll introduce Robert. Robert Longyear is a VP of Digital Health and Innovation at Avenue and Wonderly Health, a Wonderly company. He's the author of Innovating for Wellness, a book that explores the intersection of health policy and health technology innovation. So his second book is coming up on remote patient monitoring and virtual care. And I believe it's going to be released through HIMSS series in 2021. So Robert, you'll have to keep us posted on that. But he has worked across various pockets of healthcare industry, including Medicare health plans, America and policy analysis, WellCare health plans and clinical quality improvement, and Institute for Medicaid Innovation, which you might be more familiar with as kind of the mastermind behind the idea of AAA. So at the Institute for Medicaid Innovation, he led projects related to major Medicaid health plans, looking at national best practices and high-risk care. And later down the road, he worked with pharmacy-focused ML technology company, but also as a researcher, consultant, and now back to kind of the operator background. So there will be a lot for us to dig. But Robert, I don't know if I'm missing anything there. Just wanted to make sure that that's all coming in clear. But Robert, thanks again for joining us. Wait, just want to make sure that everybody else in the audience are able to hear me. Beautiful, beautiful. So I think it might be just
cut out a little bit, but
sounds good. All right, so yeah, well, Robert, thanks again for making time.
Yeah, absolutely. I do have a presentation. I think it's pretty good. So if we can run through that, that would, I think, give us some visuals and some good places to stop and have some conversations. Would that be okay with you?
100%. Let's fire it away.
All right, cool. I'm a very visual person, so that's just kind of my my preference, I guess is what I would say. So can everybody see the screen? Okay, awesome. So we're going to talk about chronic care, why it's important, particularly in the United States, and how digital tools can really help enhance the way that we deliver these services to patients. So Just to get back on my background, I studied healthcare management and policy at Georgetown, worked for the Institute for Medicaid Innovation, published 2 major research projects on social determinants of health, high-risk care coordination and care management, particularly in Medicaid, which is where we have a pretty high burden of chronic illness in the United States. Out of my thesis that I wrote at Georgetown and work that I did at the Institute, I ended up writing a book called Innovating for Wellness. It does cover the intersection between policy and some of the technology elements that often do not intersect very well in US healthcare. So that is the reason why I put that together. Most recently at Wanderley, wrote a NEJM Catalyst piece on travel nurse demand during COVID-19. That was kind of a little bit of a segue from digital health, but still digital tools improving care delivery. Most recently published a systematic review of mental health apps, looked at all their RCTs that were available on PubMed in Practice Innovations. And then my next book, this is the first time the cover has been shown publicly, will be coming out in August 2021. It's called A Virtual Care Blueprint. It's probably the most comprehensive review of remote patient monitoring based clinical programs that may have ever been put together. I read everything that's ever been written on it on PubMed and did a lot of interviews at companies. So I'm looking forward to that launching. My, I guess, biggest educational experience I should talk about is I was a leukemia caregiver for about 8 years. My mom, I lost her when I was 20 to chronic myeloid leukemia. So I've seen the thick and throes of the healthcare system from a couple different angles, both as a healthcare provider, as a student of healthcare, and as a caregiver. And the caregiver work informs pretty much what I do on a day-to-day basis. That's where, the rubber hits the road with the patient. So why in the United States is this such a problem? This is US data from RAND Corporation. It's 75% of US healthcare spending is attributable to chronic disease. Those are things like heart disease, hypertension, lipid disorders, mood disorders like depression, diabetes, anxiety disorders. We have a ton of sort of chronic long-term conditions in the United States. And according to WHO, they're often preventable. And if they're not preventable, they're often very manageable. But when they're unmanaged, they lead to costly points of care and services like hospitalization, emergency department visits, and surgical procedures. If you're here, this is the same story that everybody talks about all the time. So I'm sorry for bringing this up, but I like to set the stage for those that are not as familiar with the chronic disease burden in the United States. We also spend more per capita and have comparable or worse health outcomes than our peers in the global markets. So similar countries, similar patient populations, but yet we have significantly higher spending and comparable or worse health outcomes. So I have a problem with that. That's something I'm very interested in. And again, a lot of that spending, most of it is attributable to chronic conditions or the sort of byproducts of having those uncontrolled chronic conditions. I always like to bring this up because it reminds us that medical care is only a small part of what drives healthcare outcomes. So healthcare services, actually seeing a physician, getting a medication prescribed, it really has a minor impact on the health outcomes of an individual, wherein social and economic factors, individual behavior like nutrition, diet, exercise, and their environment combined has a significantly higher impact on healthcare outcomes. Healthcare services on this chart also includes genetics. So precision medicine folks out there, don't think I'm forgetting about you. But at the end of the day, if a patient gets prescribed a medication, they can't afford it, that doesn't help their health. And so that is a social factor that is important to address. There's a couple ways to do it. One is to invest publicly in public health, social services, health education, something that the United States does very poorly in. We really don't do a good job in investing in the places that lead to positive health outcomes at the population level. At the same time, and what I'm going to focus this conversation on is our healthcare services themselves can really be improved in terms of their performance and what they are able to affect. And so what I like to talk about is digital health allows us to improve the performance of medical care and healthcare services by better engaging with patients and collecting data with patients but it also often allows healthcare services to reach into socioeconomic factors and individual behavior factors when before it was more difficult to do that, because patient access issues, because of coordination issues, because of data issues. Healthcare services have not been particularly good at affecting individual behavior or socioeconomic factors. And in recent years, we've seen digital health companies emerge that try to do just that. Making healthcare services able to intervene in the factors that are from these other areas. When we look at healthcare services, there's kind of three areas in the United States that are of focus or top of mind. These come out of the triple aim. That would be cost of care. Big problem just showed that health outcomes comparable or worse health outcomes on a population level in the United States, and then experience of care, which is absolutely abysmal in the United States. I have to go to the dentist. I have to find a new dentist, and I really don't know which one to go to because I don't have any data to tell which ones are best. So I have to look at some reviews on some services, and in recent years, it's become more possible to do this with companies like ZocDoc and organizations that allow you to sort of rate different providers. However, it's still kind of a daunting task when you know a lot about healthcare and you really don't have a way to gauge who you should go see. We've all seen this happen in healthcare quite a bit. Waiting rooms, 20 patients, 15-minute visits, patients going to the emergency department for primary care, and unintelligible medical bills, having to navigate insurance. All of this is a horrible, horrible experience for patients. It leads to health outcomes that are bad. It leads to increased costs, and it just makes people feel horrible. And at the end of the day, we're all patients. And so why would we not try to fix these problems in our system? When it comes to chronic care, the crux of the problem is all on this slide. So if we think about patients' experience with their typical primary care physician, they have to call to schedule an appointment. That's a barrier. You have to call, you have to get somebody at the right office hours. You have to talk to another human being. A lot of people really don't want to do that. Then you have to get transportation to the appointment. A lot of patients don't have transportation. It might be too expensive for them to go there, or it's just a barrier. Nobody wants to get in the car, spend 25 minutes driving to their doctor's office, and then wait in the waiting room for another 40 minutes. Just not a good experience. Then you wait in the exam room. And then at the end of this all, you see your doctor for, on average in the United States, 21.6 minutes. When you have a condition, that's not enough time to ask your questions. That's not enough time to really robustly learn about what you should be doing. And it's certainly not enough time for your physician to spend, or your other healthcare provider to spend time sitting there with you, coaching you towards better health on a frequent basis. Then patient goes home. We hope the patient follows instructions, but we know that that is not often the case for a number of factors. This cycle and these 21.6-minute visits are driven by fee-for-service payment in the United States. So this is where doctors and practices get reimbursed for the number of patients that come through their clinic and the number of services they provide, which does not empower patients. It restricts time with patients. It provides poor patient engagement and bad experiences when volume is incentivized over quality, and it leads to those bad outcomes and costs. The current care model for most patients with chronic illness, for example, diabetes and hypertension, are about every 3 months. Sometimes it's longer than that, and patients often miss appointments as well. With digital models, such as with RPM, the goal is to extend that office visit in real time with the patient, to provide patients with the ability to manage their own health, to be able to better self-manage, understand their condition, and as well as for the health system itself to intervene and catch things before they turn bad. And so that's sort of the goal of RPM here. And that's what this digital chronic care thing really is all about, and what will be a successful model going forward. There's also, at the same time as all these technologies catching up in the world, there's an emerging psychological science of patient engagement that has 3 distinct elements. There's behavioral elements, cognitive elements, and emotional elements. And good, engaging healthcare service programs for patients with chronic illness really are able to impact all 3 of these dimensions. So behavioral is the patient's actions. It's how well they adhere to their care plan. It's how well they change and make positive health behavior choices. It's sort of what goes on with the patient and how they actually manage and handle their own health. There's cognitive elements, which is the patient's understanding of their own condition, their ability to measure their own health, and what to actually do to improve their health. And then there's an emotional aspect. There's mental health as a part of this, when mental health affects physical health. But it's also just knowing that somebody cares and is interested in your health and provides a little bit of motivation for you to make behavior change and to spend time learning and engaging with your own health. In fee for service, there's not enough time to really do these very well. And this is where the patient experience lacks. And this also has a tangible impact on patient outcomes. In a digitally enhanced program, and this is not a good slide, I apologize. In a digitally enhanced program, you're able to provide kind of two distinct new experiences with patients and providers. For patients, they're able to monitor their own health metrics when previously that's been in the hands of the provider. You can only know how your health is doing when you go to your doctor's office every 3 months. If you want to know how your own health is in your home, too bad, so sad. This supports self-management and engagement with one's health and the ability to feel self-efficacy in how you can actually affect change and improve your health by being able to measure your performance. This also allows for patients to engage with their health more frequently. It is a continuous connection to their healthcare provider and care team. So it's not like, oh, I have this one big high stakes visit to my clinic in 3 months. It's I have these small interactions over time. And those are much better for patient education, engagement, and positive feelings about healthcare rather than those like high stakes, scared, anxiety ridden visits that a lot of patients with chronic illness experience when they just go into that clinic. And so it leads to continuous support along a patient's care journey. The provider, when you have these sort of connected care, digital care models, which I'll get into a little bit more detail in a moment, it solves the patient left my office problem, which is I can't do anything when the patient leaves my office. I give them 15 minutes of my time. Here's a prescription. Good luck. That's not very good for providing chronic care for patients that are not as well educated in health. They don't have as many resources as physicians in health, and it's a big problem. So that solves that problem. 2, it allows for routing to various levels of care provider, alleviating physician burden. This is something that's very important, and this is what I stress to a lot of physicians when I talk to them, is that if you actually build a robust digital care program, some things can be handled by your nurses, by your health coaches, by your medical assistants when they come in, and the digital tools allow you to instantly triage and route to people so that physicians are not being sort of the end all be all, like kind of football carrier and, defensive line and all these other different areas that they have to handle. It can improve patient outcomes, which we know most physicians get into healthcare for, and most clinicians get into healthcare for. And then it can also open up new revenue streams for practices due to new billing codes that are available as well. So this is, I'm going to talk very heavily about RPM. There's a lot of ways digital tools can be used to improve patient experiences and cost, but I'm a big believer in remote patient monitoring programs that are more robust than just here's a device, go home. So this is how a lot of RPM programs are set up. Patients have a patient app. They may have connected devices that are meaningful for their condition. So that could be a hypertension cuff for hypertension. Sorry, coughing. It could be a blood pressure cuff for hypertension. It could be activity monitors for lifestyle medicine programs. It could be a connected blood glucose meter for patients with diabetes. And what that allows for to happen is that that data is transmitted back to the provider. And that can allow for, reaching out if something's flagged as dangerous or not good. It can allow for education where patients themselves are able to see their own data and tracking over time and say, hey, look, I didn't eat a salty meal last night and my hypertension was under control. So that is something that affects my own health. So RPM is as much about the patient monitoring part as it is about helping patients understand their own health and what leads to certain changes in that health. And that's something I always like to stress, that there's an intervention going on here with patients when you give them RPM technologies, but it's also obviously there for the supportive hands for that provider to give them eyes and ears in the home about that patient's condition once they go home. So this is typically what an RPM program looks like. There might be an app-based platform. Sometimes there's cellular devices where that patient clinical data goes directly into the EMR. I'm a big fan of an app-based one because you're able to deliver digital interventions. You can do video visits through that app, and you can allow that patient experience to be driven when they're in the home using that mobile device and also collect data and feed that back to that clinician. I like to talk about this because I think it's very important, and we'll stop here and have a discussion. So this is from Pew Research Center. And this is why this is possible now. So if you look at the top graph, that's the percent of US adults who own the following devices. You can see cell phone from 2004 to 2018, we're getting close to 100%, probably at it probably now. And then you can see smartphones, they started measuring it in 2011, and we're above 75% of the population across US adults owning a smartphone. So that's really enabling healthcare now to say, look, there's enough patients out there that can really access these technologies to make it worthwhile for us to do this. The chart below shows the percentage of US adults who use the internet. You need a smartphone to use the internet, you need a computer to use the internet, but what you can see is the age breakdown. So 18 to 29, this is only through 2018, but ages 18 to 29, you can see we're pretty close to 100%, 30 to 49, close to 100%. 50 to 64, close to 100%, but that 65 plus is that really important thing that everybody always says, Medicare patients can't use this, or older adults who often represent the chronic disease population in the country can't use this. That looks like about 75% of people 65 plus have a smartphone, or sorry, who use the internet. That's not the smartphone. I'll show you the smartphone data in a minute. So we're getting to this point in the United States in particular, this is just US data, where people of all ages have access to the internet. They have devices to do these types of programs. And so that's why there's been such a big push for digitally delivered care, particularly for patients with chronic illness, because of that cost and because of that, issues with the actual care delivery these days. So this is a big driver of why this is possible now. When we dig deeper into smartphone ownership, we can see that 53% of people 65 plus own a smartphone. That's pretty good. And this was in 2018. That number is consistently rising. We might be closer to 60% now, might be closer to 65% now, particularly during the pandemic where that type of connectivity was needed. People, their biggest pushback on this is Medicare patients can't use it. And I say, well, half of them can, at least in 2018. So that's something that I always like to say, this is a big driver of this push in all aspects of healthcare. People making less than $30,000 a year, 71% have a smartphone. So our oldest patients, many of them have access to these types of programs, and oftentimes our poorest patients have access to these types of programs as well. Health equity is a big issue in telehealth and digital health, and I like to share these stats because while there is an equity and a disparity between people who make more money and between people with different education attainment, oftentimes it's still better than what most people assume. So I always like to share this because I think it's really impactful. And it's something that comes up quite often in digital health discussions, particularly as it relates to chronic illness. Will we be creating a system where people who can afford smartphones and afford these programs get better care than people who cannot? And that's something that has to be tackled. But as we can see here, we have a pretty good starting point to be able to say, look, there are disparities that need to be addressed, but it doesn't mean that a lot of folks in these populations can't use these types of programs. I'll stop here before I go any further and see if there's anyone who wants to talk about this.
All right.
I also just keep talking.
Good stuff. I'd love to maybe ask like a quick question in terms of like well, the COVID-19's impact obviously like around this industry. So like I was just at a TTX conference a couple of weeks ago, and one of the things that we keep saying is COVID-19 has been kind of a silver lining for digital health, but I think more so for virtual visits and especially remote patient monitoring, right? So kind of curious to hear in terms of the adoption rate, or just from kind of the operator and on the ground perspective, how much impact there was, and if you felt it on the ground.
Yeah. So, I mean, the receptiveness to RPM in particular, or to telemedicine among providers in particular, went way up. So like health systems, like really, they were looking to do this in like 3 to 5 years, right? They were like, that's on the strategic plan. COVID-19 was like, okay, our strategic plan needs to start now. I do a webinar with the head of primary care at ChenMed, and he said that they had like telehealth programs on the docket for 2.5 years from now, and like back last March they were like, okay, it's time to do it. And so that was something that I thought was really interesting. But now when I get into conversations, there's a lot of inbound interest, like, hey, RPM, we want to do it. Like, let's evaluate you. Like, this is something that's kind of top of mind at this point. Um, it's been interesting for that. We've also seen patients like starting to get more exposed. So like March, April, tons of claims related to telemedicine, which is often just audio visual conversations with a physician. So RPM is still a couple years behind your typical telemedicine crowd. But that really grew quite substantially. And then the research world also said, oh, maybe we should pay attention to this. And when the research world pays attention to it, starts generating knowledge, starts generating data, the policy folks start to listen. And so that really generated a lot of buzz in Washington in particular, which is really what's needed. Policy changes in Medicare and Medicaid are really what drives substantial adoption and the ability for most patients to access these types of services. So the measurement started, and you can't change what you don't measure. And so that really also was a big thing, because all the researchers who want to publish are like, I guess we should look at the telehealth data now, because like people want to know about that. So that driver alone was also very helpful, I think, for the next 3 to 5 years. So that's the answer everybody gives. But I think that it's been quite substantial as an impact.
And we have some comments kind of coming in also with some questions in terms about how great the presentation is, kind of pulling together the right information and the
Thank you.
expertise. That's definitely a positive sign. And got a question there about kind of like wanting to see the market for 65 plus years old with different segments, especially by Medicare coverage, and breakdown by seniors with 2 or more chronic conditions, and smartphone internet by the same segment. So kind of thinking a little bit more about the Medicare population, and also those who are suffering from multiple comorbidities. What do kind of the telehealth utilization or access to, I guess, the smartphone technology and internet, in those like.
Yeah, so if you're over 65 in the United States, you are, in your US citizen, you are eligible for Medicare. So anybody 65 plus is eligible for Medicare, whether it's Parts A and B that you sign up for, whether it's Part C, which is Medicare Advantage, or delivered via private companies. So yes, that population is certainly has access to RPM and telemedicine, because Medicare usually is where most coverage begins. And so, that particular population, you segment it. I usually segment from 65 to 75, and then 75 beyond. The 75 beyond, the rates of smartphone ownership are much lower. Rates of chronic conditions are higher. But that population, the opportunity there is really with hands in the home. So that would be the home care crowd, the people who work with sort of aging in place, the people who do sort of teleconsults for patients that really do have some extra hands in there to help out. That space is growing, but then you have sort of the well Medicare population that's from 65 to 75, that's still pretty ambulatory, moving around, take care of their activities of daily living very easily. That's a really good target for digital health and for RPM in particular. So that's how I'd answer that question. The 2+ chronic conditions requirement is not for RPM billing, it's for CCM billing. The CCM program was the biggest Medicare failure that's probably ever existed. Reimbursement was far too low to gain adoption, and they launched in about 2015. And they were like, start doing chronic care management for your patients, we'll reimburse for it. Like I said, the reimbursement was too low, requirements were pretty rigid, and you did need patients with 2+ chronic conditions. So that made it a lot more complicated, but RPM, it doesn't require that. So that's something that makes the RPM billing program, well, since we're getting into billing, a lot more robust and able to fund a lot of these virtual digital care programs.
There was a comment by I think Dean Tucker there, but I actually wanted to ask a quick follow-up question to that. Is looking back to kind of the CCM versus the remote patient monitoring. Actually, I'm surprised that I never heard of it. Chronic care management, I guess, is what CCM stands for. So, like, I mean, from its kind of face value, or those who are kind of hearing it for the first time, it sounds very similar, right? And like maybe it is by eligibility of like, or how it's getting reimbursed, maybe that these 2 programs differ. But could you speak to a little bit more about, why the first was somewhat of a failure case where we're kind of viewing the RPM as kind of the promising future, so to speak. So what has been the difference between the two?
Yeah, so CCM was launched by Medicare with this idea that we needed to do something for patients with chronic illness outside of the four walls of a healthcare facility. It was really one of the first efforts by Medicare to say, like, we need to modernize a little bit. A lot of CCM programs do use technology to make them more efficient and a little bit more cost effective. And the program's been around for longer, so more providers know about it. And it's just basically designed for patients with 2 or more chronic conditions. And the idea is you're just trying to do things that keep patients out of the hospital and they have access to their providers 24/7. RPM came along 2018, 2019 with the goal of actually collecting data from patients, where you really do need tech front and center. CCM, like, you can do it over the phone. But the RPM program is tech front and center. Reimbursement is higher. And so it really provides the flexibility to be able, through the fee-for-service payment mechanism, to launch these programs in such a way where it is paid for and there's reliable, sustainable financial revenue stream for it. And it's really tech forward. The reimbursement rate difference is what really allows you to do that. It's quite substantially different between the two. So that's my take between the two of them. Both of them, the goal is to improve chronic disease management in the population. So it's just 2 slightly different requirements to build those codes to Medicare, and 2 slightly different requirements for which patients are eligible for it. So that's my take on those 2 programs typically. And I think RPM is going to continue to evolve and become the main driver of virtual care programs. You have your typical professional time for clinicians that are billed for telemedicine. But RPM is something a little special. It's a little bit more, it's relationship based. It's every month. The goal is to really build a chronic care program that is more effective and that is longitudinal, rather than these like episodic things that telemedicine still really promotes, because it's built in time intervals. Whereas RPM still built in time intervals, but designed to be done every month.
Sounds good. So let's get back, I guess, to the presentation.
Awesome. So what do patients think about RPM programs? So this is all from the literature, and the first 2 up top are very positive. The bottom 2 are sort of concerns patients express. The top one is gained knowledge and improved positive health behaviors. That's what we want to do for patients with chronic illness, as I mentioned. 2, improve peace of mind and security from supportive monitoring. That's improved like quick access to those providers. And it's, somebody's watching out for me, making sure that my metrics are okay, and they're going to reach out if something's wrong. Patients, that they say that they like it. It comes from a number of systematic reviews that look across a lot of studies. The patients do express at the beginning of program enrollment concerns about additional burden and work. So that's why it's important for RPM programs and tech providers to build something that is seamless and fits into the patient's life. So it shouldn't be too much work. It shouldn't be a lot of paperwork. And similarly, the last one is fear of loss of interpersonal connections and being confused by data. So making sure you present data to patients in a way that's patient-centric and that's at the appropriate reading level. And then also making sure that there's a human being involved in your RPM program. I always talk about RPM programs that fail are ones that give a patient a device in the clinic, tell a patient to go home, and then patient throws it promptly in the corner and doesn't use it. Then the clinic's out for the device, or they tell the patient to go to CVS and pick up a device and write stuff down on paper. Doesn't work very well. Patients throw it in the back of the box and put it in the corner. And that's been the experience for the past like 10 years since we started getting these cheaper medical devices available for patients to monitor their blood pressure in the home or blood glucose. And so it's important to still have that human element with the data transmission piece. And the coaching and the human element really keeps patients engaged, because there's somebody they know that they're accountable to. So patient will, like, health coach, clinician will call patient and say, hey, I saw you weren't using your device. We noticed that. And that function alone really keeps RPM programs more robust and increases that engagement over time with patients, which is very, very important. So the other thing I get a lot from providers and skeptics are, this is new, like, how do you know this even works? I usually pull out this slide and I say, if you go to PubMed and look out remote patient monitoring, you can see that there's literally thousands of studies that have been published on this, stemming from cost effectiveness to clinical outcomes across a wide variety of conditions. And I say it is a very robust sort of studied program. And the problem and the reason it hasn't become more widespread or standard practice is that there just hasn't been a reliable payment for it, in particularly in the US. And so 2018, 2019, and now 2020 have brought more flexibility to payment for this. And so adoption is starting to accelerate. The other reason we haven't had adoption is what I showed earlier, which is that smartphone ownership. So it hasn't been enough patients to justify the investment, but now we're getting to the point where most people have smartphones. And so that really allows these programs to exist and be a reasonable investment for healthcare organizations. This is from a large evidence map for telehealth. And so this first one, as you go along the x-axis on the bottom, it shows the weighted benefit to patients. So that's more positive results and outcomes for patients. And if you go on the top, that's just more patients studied. So that kind of lends itself to like how confident we are in the weighted benefit. You can see that chronic conditions, mixed programs that address like weight loss and diabetes or hypertension and diabetes have very, very positive results. You can see cardiovascular disease, diabetes, and behavioral health have pretty good, strong benefits from telehealth programs, be it RPM, be it just telemedicine. They see significant benefits to access, patient outcomes. And so those conditions have been the most studied. Hypertension, diabetes, depression, they're high in prevalence, but they're also, they lend themselves well to these types of programs when it comes to monitoring. So this looks the same, but it's different. So this shows the function. So that was the conditions, this is the functions. And what we can see here is the positive results along the bottom. And we can see the number of patients, which again tells us like how confident we are. If you have more patients and you still get positive results, you're gonna say, okay, like I think this probably works. The interesting thing here is that among all the systematic reviews included in this really big study, communication and counseling, which is health coaching, it's spending time with the patient, it's doing so virtually, and then remote patient monitoring are those two there. But the multiple function is when you combine communication and counseling with RPM. And what you can see is that the weighted benefit is very strong when you combine them. You can also see that we're pretty confident. There's 10 systematic reviews that show that this is proven weighted benefit for patients. And so it's a very, very strong level of evidence. And the researchers who did this for the Agency of Healthcare Research and Quality concluded in their research, and they said, RPM works, we need to figure out how to implement this. And that's where we're at now with reliable funding mechanisms and with technology available. It's time to start implementing this into chronic care models across the country and across the world even. So here's a specific case study. This is on diabetes. There's two studies here. There's a systematic review at the bottom, which also shows positive outcomes when it comes to health outcomes, but I want to focus in on this graph. So this was a 330 patient randomized clinical trial by Livongo. And it was type 2 diabetes patients with pretty out of control weight and their glycemic control. And they used an RPM based model with health coaches that basically had escalating levels of health coaching. This is that communication and counseling function with the data collection itself combined. And you can see with just the Livongo devices alone, there was a significant benefit in A1C, which is that glycemic control for diabetic patients. But when you get to more intensive coaching, the Livongo plus the scale, plus the intensive coaching, those connected devices, plus a human being there to coach somebody along, you can see a tremendous decrease in A1C down to pretty reasonable levels. And so that's one of the, like, this is a specific study, specific population, specific clinical program that shows the benefit of having that human element, that human coach, that chronic disease management piece, plus the connected devices to be able to lead to clinical benefit for patients. And so this is what I see as being the dominant model for most high prevalence chronic conditions going forward. Those connected devices, which keeps patients engaged, empowers patients, plus that coaching resource that is educated to help engage with patients, that can help patients stay on their care plan, and that is receiving direction from a treating provider, a physician or qualified healthcare provider. And this is good because that provider then becomes the quarterback and the expertise behind the care plan, which has always been important and shouldn't go away. But these physician extenders, people, nurses, diabetes educators, people with their own domain expertise can really come in here and take a lot of the burden off of our physicians, which is causing a lot of burnout in the country. We can also make sure that we extend the amount of time we're spending with a patient. And that time component for the physician extenders, for RNs, for diabetes educators is cheaper than having a physician spend all their time with this patient. So it becomes a much more efficient delivery system that's also very, very effective. And that's why this model is going to be dominant going forward, for sure. So RPM technologies have also become less expensive since 2004. There was a big study that was done with 13 cost studies in the space. 2004, it was pretty expensive to do this for patients. You often had to provide the devices because they didn't exist. So that was about $8,000 a year to operate the program per patient. And now we've gotten down to like $275 to operate a program per patient on average. It's not a great estimate because the authors didn't really understand the ins and outs of RPM, but it shows that we are getting cheaper and more widespread available for these devices, which has really allowed for these programs to become more and more successful and more available for patients, and why we're probably having this conversation right now. So the most stable funding for RPM care models comes from Medicare. These are the national averages for the codes. So there's a one-time patient setup and education code. There's the remote transmission of data that needs to occur a certain number of days throughout the month that can be billed every month. And then there's 20-minute intervals of clinical staff time or provider time that's spent with that patient. Those 20-minute intervals really just requires review and communication with the patient about their care plan. So what can be done in there is a number of different things. Some RPM providers will just take that data, and when an alert comes up, they will say, oh, I need to reach out to this patient, and we'll try and hit 20-minute thresholds. What you can also do, which is what we do at Avenue, is you can have a structured visit with the patient. That's like an office visit, telemedicine visit with a health coach that is not just like when the patient needs it, but it's structured on a reasonable basis to actually make sure that you're delivering education and value to the patient consistently rather than waiting for something to go wrong. The waiting for something to go wrong is a good model. It's far better than what we have now, which is nothing. But I see this RPM programs more for educating patients, improving their self-management behaviors rather than just being another sort of reactive part of the cycle. Better, again, than what we have now, which is nothing. But it's something that can be more sort of sustainable. It's like if you teach a man to fish, he'll eat. Sorry, if you catch a man to fish, he'll eat for a day. And then if you teach a man to fish, he'll eat for a lifetime. That's my view of how RPM programs should operate and how they should be viewed, rather than just the function of data transmission. This is from a study on CCM, but it also applies to virtual care and RPM programs. These are the four main barriers that practices and health systems face to launching one of these programs. So basically upfront capital that's required to invest in this. You have to hire people, you have to get the technology, you have to like build your workflows. It's expensive to launch one of these programs. You have to have access to clinical workforce. You can't necessarily take a clinician or a diabetes educator that's working in person and then suddenly transfer them over to virtual. A lot of times you have to augment that staff that already exists. There's a workflow disruption for physicians. So they're kind of in their groove now, seeing patients in person, and then suddenly you want to do virtual ones. That doesn't work very well. So that's a big barrier. And then navigating technologies, there's a lot of providers, a lot of vendors, not a lot of good, like reasonable, like safe information out there. So that's something that's really caused a lot of issues in chronic care management implementation. And now it's also a barrier in RPM program implementation. So I'll stop there and see if there's any questions. I'll pop back to this slide because I think it's one of my favorites. And then I can go further if we need to, but we'll stop for questions and more discussion.
Sounds good. We're seeing some questions come in around. I think we'll attack kind of the RPM assurance of privacy of patient data. And I think Matthew was kind of chiming in and saying like, how does it kind of play a part, especially with GDPR and HIPAA in place? And I'll probably even add on to this question by saying that with COVID-19, there's been a couple of reports in the space about how cybersecurity has been a big issue in the virtual care RPM space, as a lot of the hackers are kind of, looking out for where a lot of these patient data, where PHIs are living in, and it's in virtual care, it's in RPM, and certainly it is to say that we've grown very rapidly. I think over the last few months. And the adoption rate has, I feel like, never been higher, and the reimbursement is there to kind of vouch for it. But also with the rapid growth, there's been some holes in terms of these things that are almost like a growth pain, and it will probably catch up along the time. But so wanted to hear from the operator's perspective, what some of the conversations that are kind of taking place on the ground in terms of cybersecurity and privacy.
Yeah, so I bucket those in two. So cybersecurity, anything digital is at risk these days. So this field is not immune by any means. I'm by no means an expert at this, so I leave that to the technical people that tell me that if I house this in AWS, that it's secure. So I'm not an expert on that by any means. The HIPAA stuff is a different story. So there's a couple questions in here about who owns the data in RPM systems. So who owns any patient data? That's a question healthcare has been grappling with for a number of years. And so somebody asked about GDPR as well. So I believe GDPR is the European data protection one in the EU. California in the United States has one that most tech companies have to be beholden to. And so like, basically, if you're a consumer company like Snapchat, like you have to be, as a user, able to request that they delete your data. So you do own it, at least in California. And so most tech companies adhere to that. If you're a healthcare company, that law has a HIPAA pass through. And so if something's PHI, it's then governed by HIPAA. And HIPAA is a very complicated, it's not that complicated, but it's become very complicated in the world of healthcare, where who owns the data, who has use to it, who gets to consent to their data being shared. At the end of the day, again, not an expert at this, but like for RPM, for example, patients really should be the ones in control of their data. And so what needs to happen is you do need to convince and make patients feel confident that their data is secure and that it's private, and that you will protect it. If you lose trust with patients there, they probably won't engage with the program. Just like any EMR vendor, just like any health tech vendor for a healthcare organization, most of those contractual relationships are governed by a business associates agreement that suggests that or that enforce HIPAA between both organizations. So whether you're a covered entity by HIPAA, any of your vendors or organizations will be covered by a BAA typically. So you and your processes then must comply with HIPAA. So the cybersecurity part, people accessing PHI, all that fun stuff, I can't comment on that. It's obviously a big problem that everybody in tech and everybody in any organization is grappling with. So I think that's really important. And in terms of like HIPAA protection, you have to treat RPM data just like any other PHI. So you have to keep it secure. You have to control who has access to it. Patient has control with where it gets shared. So that's stuff that's very, very important. And so consent to collect patient data is a big part of an RPM program. It's a big part of any clinical service. You do have to make sure patients are able to give informed consent when they say, I want to participate in this program. So patients consent to the collection and the use of their data, who it gets shared with, but they also consent to, yes, this is a clinical service. I consent to receive this clinical service. So patients aren't forced to this. They have to opt into the program. And it's something that falls under any, like, going to a surgery, you need to make sure you're able to give informed consent. You have to document that as an RPM provider. And so all those typical healthcare operations when it comes to legal protection and HIPAA must be followed for these programs. But I think the data privacy and all of that will continue to get worked on. And again, I'm not a legal expert. I know you guys do have a HIPAA lawyer coming in, and so I actually have worked with some of the companies he's worked with, so he's very good. And I'm trying to see what else is on here.
Yeah, Ben Fisher was saying, yeah, how great Robert is also in this space as well. So, digital health community
Yeah,
always proving to be kind of like a tight knit group of big players. So go ahead and register for the 4/6, April the 6th webinar. That's when legal issues, that may arise when digital health or healthcare goes digital. And then, Robert, I guess we could go back to the next question, which was around, maybe physicians working with health coaches. I think this was another good question asked by Tony. Are they
yeah.
or qualifications? So I think I was giving a little bit more about CDEs, which was the case for Lebongo. I know that
Mhm.
coming from the pharmacy space, that a lot of pharmacists are involved in the diabetes kind of code, certified diabetes educators. I know that they kind
Yeah.
of changed the title. They're now, I think, diabetes education specialist. I forget what they're exactly called these days. But could you speak to, like maybe other disease areas where this may be more common? I'm familiar with this case in diabetes, but I wonder if it's the case for hypertension or any
Mhm.
other disease indications that we looked over in this space.
Yeah, so there's been recent efforts in the past 10 years or so to train clinicians and even creation of new specialties as well as pharmacists in chronic disease management principles, which are more inclusive than just physiology. So a lot of this RPM, digital health, and that first slide I showed with all those different factors gets into this idea that, like, medicine for so long has been focused on the biomedical, on the physiological, on processes that go on in the body. And that's great. We do that pretty well. We've made some crazy gene therapies and drugs and stuff in the US and around the world that really treat conditions that are incredible. My mom, for example, was on tyrosine kinase inhibitors forever. And those drugs kept her alive from a disease that killed people in the 80s and 90s within a short amount of time. And the amount of investment and technology that's come out of, like, the pharmaceutical industry and medicine in general has been tremendous over the past 30 years. Where we're lacking is in the softer side of the world, which is behavior change, which is nutrition, which is education, which is patients learning how to inject themselves with insulin safely. And so that's really created this need in healthcare to train a new class of clinicians that are more longitudinal focused, more preventive focused, more lifestyle focused. And diabetes educators, just because of the increasing prevalence of diabetes, particularly in the US, has emerged as a very important clinical skill set that nurses get certified in, LVNs get certified in, and then people just generally become certified diabetes educators. And it's just a specialized skill set about a very prevalent condition that helps patients understand all the aspects that impact their condition and over time. So they're becoming more and more prevalent, and it's a workforce generation issue. So the more diabetes educators we train, the more health coaches we train, the more chronic care management nurses we train, the more available they become to the general public. And so we're still in the early days of this, and health coaches working with physicians, where the ultimate goal back in, like, the old days of primary care and family medicine, where the doctor would sit there and spend an hour with the patient if they need to spend time with the patient for an hour. And the family practice physicians, the internal medicine physicians, are miserable right now because of the pressures from fee for service payment, where they have to see 20, 25 patients a day, and they don't have time to spend extra time with that patient. Otherwise, they would be doing poor financial things for their practice, and they themselves wouldn't be able to stay afloat and pay their staff. And so having people who are cheaper, they don't make as much money as a physician, but still are very, very effective clinicians at spending more time with patients, sitting in a room with them, going over how to treat their condition, educating them on diet, pharmacists doing medication reviews, those types of staff that have previously sort of been sidelined, or in the case of pharmacists pushed behind the retail counter, are coming back into healthcare to take the burden off of physicians, but also because their education system and their schools have been training them on these chronic care programs and chronic care management, which is becoming increasingly important, and now more possible as we get better engagement and new technologies with patients. So that's something that's been happening. A health coach can be, there's lay health coaches that might not have a clinical background. There's health coaches that are RNs that are extremely well trained and educated in physiology and in health, but then also get sort of this training in motivational interviewing, which is a technique to try and change behavior, to help identify barriers for patients so that they themselves can build confidence and work through their care plan and then their care journey as well. So, those are the types of things that are starting to happen and are being enabled by technology. So the clinicians will never be taken out of it. There's a lot of companies that are trying to automate chronic care using chatbots and AI, and I think there's been some decent outcomes coming from it. But you lose that empathy piece. You can kind of fake empathy using the way that you form words and you respond to patients. But at the end of the day, having somebody else sitting across from you or virtually is very important. And knowing that somebody cares, somebody giving you the motivation to like go that extra step for your health, that's still very, very important. You won't ever lose that healthcare. The goal is making those clinicians more efficient, making them more efficient, more effective, and being able to spend more time with patients, automating tasks that are menial and documentation based, and allowing people to get back to that relationship with the patient, to actually spend time and educate them on their lifestyle, on their medication lists, and to solve those problems in partnership with patients.
And the next question that we had, and you'd love it. We're kind of, let's continue this chain of questions that I keep learning from the chat as well. Are there certain aspects of RPM that are more important to different patient age groups? So thinking about different kind of segments, and I guess it could be age groups, it could be disease indications, which I think talked about a little more. But are there any kind of research or thoughts around different age groups need for RPM?
Yeah, so that's a tough question. I don't know the answer, like off the top of my head. I can guess a little bit. So I worked for an app company that was focused on medication adherence in adolescents with cancer. And that population all has smartphones. They're on their phones all the time. And they all found it very easy and acceptable. And their biggest issue was remembering to take their medications. That's about 40% of medication adherence issues. And the patients thought it was very acceptable. So you do have like a level of acceptability that's increased in younger populations that are digital natives. They expect this type of experience. And if you look at the healthcare market and why digital tools and why the digital transformation of the industry has been so impactful and of interest from investors and new healthcare organizations that have been successful, it's because you have millennials and you have, even you have Gen Z and you have Gen X that is becoming, everything's becoming digital. It's the Netflix effect in action. Everybody's expecting to get things in the home. They want to get them when they have them available. And so that younger group of people who are not baby boomers and who are not older than baby boomers, like really expect this now. And so that's one of the things I'll say from a generational perspective. Older adults, you engage with patients differently. You can like onboard younger patients via email. You can send them a Slack message. You can send them a DM on Instagram, and they'll be like, sure, let's do it. Older adults, when you're onboarding, a lot of times requires personal touch. You have to have a call center. Sometimes you have to have another person on the other end. Sometimes you send mail. So the ways that you engage with different populations is different among sort of the digital native generations and sort of people who have since adopted digital experiences. And so I'll say that. I'm trying to think if there's anything else here.
While you think of that, Beth, you had a quick question in terms of what was the app? Was it?
Yeah, so I worked for a company called Montuno Software that produces the app Dosecast. And so it was one of the early medication management, medication adherence applications. You may have heard of MediSafe. They just raised like $30 million. So MediSafe came afterwards, and has done extremely, extremely well, with sort of working with pharmaceutical companies on medication adherence. And so that was the app. And it was studied at the University of Utah, looking at young adults with cancer, and medication adherence is a big problem with those that patient population. And so the study that was done there was just really about acceptability, and so younger people like really did get value out of it, and older adults do too. And the benefit of older adults when it comes to RPM programs is that a lot of times they're retired, so they actually have time to spend. That might take them a little longer to learn how to use an RPM program or learn the new app, but they have time a lot of times to spend on that. And so that's sort of an area that can, offset a lot of the like digital native, digital issues, digital divide problems. So that's probably what I'd have to say. I'll tell you, most of the research of patients with chronic illness like diabetes and hypertension has been on a Medicare population. And so most of the studies that are included in here are based on older patient populations. You don't have a lot of 18-year-olds, 20-year-olds running around with hypertension. And so like, if you look at the hypertension studies, it's mostly their average patient age is older 50s or even into the 60s. So that's something that I will add about this particular research here, and most of the studies in this space.
And then next question was from Martina, and I saw that Martina, you had gone back to a question about who owns the data in RPM system, and also brief touch on high trust versus HIPAA. That might be a little more relevant topic for.
Yeah, it's a little technical for me.
Yeah, that might be a little more relevant when that comes in, and I think that we'll save that question for then. But if you could dive a little deeper into who owns or should own data in the RPM
Yeah.
system.
So patients should own the data at the end of the day. And we're grappling with that at a policy level across industries right now. Like, should you be compensated if somebody sells your data? Is that your property? Those things are certainly for the courts and the legal system and the policymakers to really sort out. What I will say about HIPAA and patients' ownership over their data is patients should, and they do have control over who sees it, who has access to it, and they should continue to maintain that. I will also say that while it's been very poorly implemented, and a lot of providers push back on this, you as a patient can go request all of your health records. You can go get them, as much as the organizations make it difficult for you to do that, to go in there and say, this is my data, I would like to have it, or please send it over here. That is within your rights, and the organizations do make it difficult, but that is something that patients do actually have ownership over. But the system has historically held it very closely. And that's, again, one of the areas where I think RPM empowers patients, is that you now can measure your own health and have some guidance with that, as opposed to relying on the system to get all that information about yourself. So no longer, like, if you're wondering how your hypertension is doing and you don't have the ability to measure that at home, you have to go to the doctor, who then controls your health, and your understanding of your health. And that inherent paternalism in US healthcare in particular it causes a lot of problems, but that's really what it is. It's that, oh, we are the health system, you come to us when you need help. And RPM to some extent is like a democratization of the ability to like measure your own health, to be able to have control over it and to be able to understand it. And that's why I like to talk about RPM, not just as like the remote patient monitoring, which is, again, it's a paternalistic term because we're the health system, we're monitoring you, but it's more than that. It's here's real-time data on your health. So RPM, the term itself is part of this, like, we will own your data and monitor you, rather than you monitoring your own health and getting access and support from your providers as needed. And that's something that I think is starting to change and be acknowledged in healthcare. It's a reason why a lot of people have distrust with the existing system as it is now. A lot of patients who we don't want to go to the doctor, aren't interested in engaging with healthcare, they don't trust them because of this like historical problems, because of racism that's been pervading the healthcare system for years, and for this idea that, oh, we own your data, haha, come to us and we will tell you what's wrong with you, and that is bad for patients. It's bad for all of us, and it's something that I think RPM starts to change a little bit.
Beautiful. I know that, I've been kind of taking the questions on the chat, but we have someone in the audience that was kind of driving and also wanted to ask a little bit more on integration and the longitudinal care aspect. So Justin, if you could unmute yourself and, ask the question away.
Yeah, thank you, Dan. And thank you for doing this, Robert. It's really good so far. My question is just, it's along the lines of the diabetes care aspect of RPM and Livongo and Dario and everybody else playing in the space. And one of the things that came up, I completely agree with what you've said about just RPM and the live coaching combined working really well from everything I hear from people. The thing that's I'm curious about your take on is how long before it really gets integrated so it's not so fragmented. And what I mean by that is like the patient comes in and their A1C is under better control because they've been using coaching, but the endocrinologist or the PAC might not know why, because they don't get that data because it's through the employer and like everything's not talking. So
yeah,
it's kind of my question.
Yeah, so, oh gosh, fragmentation in healthcare is always a problem. I mean, we have three major healthcare markets from my view, right? You have the Medicaid, state, low-income population. And then you have the commercial employer-controlled healthcare market. And then you have Medicare, which is national. And they all really operate very differently, not to mention the fragmentation among all the individual provider organizations. But if you just look at insurance markets, their financial systems, incentives for innovation are all distinct. So our company works in Medicare because of reimbursement codes that are there. We don't even touch employers like the Livongo, Omadas of the world that really are talking to the employers. The sales cycles are easier. It's a pretty big market. And you don't have to deal with the billing system, which is very restrictive a lot of times. So with your example where you might have RPM data going to a service provider that contracts directly with the employer, and then that patient then goes to their endocrinologist, that endocrinologist doesn't have data, that's a big problem. We see it today outside of RPM in just electronic health records where, here's an example. So when my mom was sick, we were in Northside Hospital in Atlanta at the bone marrow transplant unit, and they were on Epic. And all of her records for 3 months of inpatient care, chemotherapy, all this fun stuff was in there. And she was cared for by this outpatient hematologist, oncologist physician group that had an office that was in the same building. So when she got discharged, we went home, and the next day we had to go back to the outpatient office for the first visit outpatient. I ended up going back there. The outpatient clinic was on a different EMR. They were in the same building, same physicians, different EMR, and they had none of her records from inpatient. And so the provider that was there to see us on this day didn't know any of her diagnoses, didn't know she had developed congestive heart failure in addition to her leukemia when she was inpatient, and didn't even listen to her heart for crackles and fluid around the lungs and around the heart. And I was like, this is the same group, and you don't even have the data from inpatient in the same building. They had to call the nurses on the unit and get them to export it and send it over. And this happens everywhere in the United States. It happens all the time. And interoperability among electronic health records is not even there. And there's been a lot of Office of National Coordinator changes that are trying to get them all on a similar program interface so that they can share data. But physician practices will still fax things to each other. And sometimes they'll print out the EMR data and then fax it. And it's just that's a problem in and of itself before we even get into these more real-time patient care models, these more data-driven models like RPM. And EMRs are not very well set up to take in real-time data. They're set up for encounters that are episodic. So patient comes in on this day at this time, and we record this information. They're not very well set up to collect RPM data on a daily basis and then set it into the EMR. That's a huge data problem.
Yeah, that's what I worry about.
Yeah, real bad. So the employer market is one thing, right? Where employers are trying to innovate around the health system. They're like, look, I'm at risk for this patient population. We're going to have to do some of these new clinical care models. And, I don't care what happens for the network that already exists for endocrinologists. They're like, I have to do what I have to do to reduce risk. Then you have Medicare, which is a different story where patients more are in the care of a primary care physician. They might have a couple different specialists that they see as well, but that's a little bit more centralized. So this comes down to a conversation if we're ever going to solve the fragmentation and the data issues. One, it can be done with technology, and the best way to do it is with a national patient record identifier, which we do not have in the United States. So that's been talked about for a while. I think it was there's a bill moving through Congress, and being able to have each patient assigned a number so that any EMR in the country can then track those records to that patient is something that will solve that problem. So then Livongo's record, if they work with an employer, will have that unique patient identifier. And then if they go to an endocrinologist, that endocrinologist will be able to pull from, cloud, wherever. And this is a gross simplification. It will never work like this, but if you have that record piece, you're able to pull this data from a number of different sources and link it to that single patient. And even we have difficulty matching patients between software systems, right? You have different main index keys in the database, like some use date of birth, some might use name, some might use social security number. And being able to match patients is still difficult. So, what is the answer to this? There's a tech solution which you hope will happen. It's going to require regulatory movement to force companies to actually operate together. But the real solution is single payer healthcare, which people think is a bad word. But if everybody were to get Medicare, then Medicare centralizes everything. And then Medicare says, okay, unique patient identifier, Medicare number, everybody bills us, we have all the claims data, we have all this information, and that's really the only way that the fragmentation gets solved. So it's a problem for sure. And that's why our company, we try to stay very close to the PCP, and make sure that if we're offering RPM, they have that data. We hope that the PCP stays PCP for a really long time. And that's kind of the best way to do it. If we want to improve healthcare in the United States, the secret is investing in primary care. It's making sure patients have access to it, and it's building these types of data-driven models at primary care where patients consistently receive longitudinal care from the same place. It's going to be hard to do that for sure.
Had a quick comment there, and actually this is great. So if subsequent audience member would like to maybe join and ask the question, via audio or with the video on, that's I think going to be wonderful. I think to the point about how a single payer health system is probably one of the better kind of situations where this kind of aggregation of data and creating almost like a if you may, the national patient identifier, right? As you said, it's similar to MPI almost, what we have in the space of provider identifier. I was just sharing a link in there that was from Estonia, a country in Europe. It's super interesting. I was just pulling up a card here. I'm also a e-resident of the country there, and what this allows you to do is quite fascinating, right? It lets you go into healthcare, and basically you have the card, and it gives you a same kind of experience all throughout the Estonian healthcare system. And the funniest thing I heard, I think, was where say that you God forbid fell on the street and lost consciousness, and there's no way to figure out what, or ask you even of your drug allergies, what your comorbidities might be, what your last results might be, things of that sort. They created a pretty interesting system with this this e-card that I was trying to show. I don't know if I was showing through, but it's quite interesting because you're able to now say, for example, a bystander or a emergency personnel is able to then take your card and swipe it into their device and pull out the data, so to speak, that's been from your previous care. So certainly interesting model to think about, and hopefully with the adoption of digital technologies that we've been seeing, it won't be too far of a future that we're talking about here in the States as well.
Yeah,
Uh,
and Taiwan has a similar card as well, with their national patient identifier, and I think it pulls up like the last 6 visit records or whatever. Yeah, we don't have anything like that in the U.S., and it's a shame.
um, Another question that we had was from Thomas, which is around Medicare Advantage, a prime market for RPM, and maybe we'll kind of end with that question, and around kind of the pricing of RPM. I want to even add, like, we've been talking about kind of fee for service, where FFS kind of payment scheme, for remote patient monitoring. But as a lot of our industry is heading towards kind of, or at least asking for a lot of that value-based care, model, or looking for more kind of ACOs jumping into space and taking an
Yeah.
interest, the holistic kind of disease management. What are some of the payment schemes that we'll likely see in the future for RPM?
Yeah, so if you think of about fee for service, and I'll answer the Medicare Advantage question too, but if you think about fee for service, basically what you get with RPM is if you do meet the billing requirements, which is easier said than done, you get almost a capitated rate to take care of patients with RPM, because you're trying to do it on a monthly basis. And if you keep patients engaged, you get to keep billing the code. So fee for service payment is really a good carrot. It's an incentivizer of these programs. It can be a revenue stream for practices if they're able to implement this. And so it's a good way to incentivize providers to start thinking about this way, because there's pretty high reimbursement for it, quite honestly. And you can run pretty strong program margins with fee for service payment and RPM. The true like place where digital care models for chronic care will be the most successful will be in a full risk primary care situation. And what I mean by that is providers that accept full risk for their patients, they basically get capitated payments on an annual basis to care for their patients. They'll pay claims in the hospital. They are then really incentivized to look at innovations and care models that keep patients out of the emergency department, keep them healthier, keep them from being hospitalized, or if they are hospitalized, moving them to that lower acuity level of care very quickly. And the natural place for technology in those models, and this is assuming, which I think I substantiate, but if we assume that RPM is effective at improving clinical care, if we assume that it works very well for patients, then full risk practices, full risk care organizations will then want to adopt it to be able to engage with patients. What does this mean for them? One, they have reliable revenue coming in because it's not tied to billing codes. So if you have a full risk practice, you can do RPM in the same way you would with fee for service, but with less restrictions, and your funding is guaranteed even if a patient decided to stop using it. Two, patients can engage with you as much or as little as they want, and it doesn't affect your revenue. So if a patient prefers to talk to a nurse for 5 minutes, or a health educator for 5 minutes or 10 minutes, they want to do it over the phone and they want to do it on Tuesday, fine. That's fine. That's what the patient wants, and we're available to be able to make that happen. If you're doing it in fee for service, you need to make sure you get at least 20 minutes of time interacting with patient, or at least reviewing the data. And so those billing requirements are very rigid. Full risk practices, value-based practices that have some flexibility are then, able to be more flexible with how they implement these programs, who's involved with them, and how they care for patients, as well as patients being able to choose how they engage with providers. So like in some circumstances, a patient may never want to show up to the clinic. They may just want to do a phone call. And in a full risk practice, that's fine. And so that's, one of the things that I think will drive adoption of these different models. But the fee for service payment is very good. Majority of healthcare in the US is still delivered via fee for service. Medicare, again, is the most consistent RPM payer reimburser. So Medicare Advantage has to cover it, and so does Medicare, traditional Medicare Parts A and B. And so that is, you know, a really robust reimbursement space for this. It's also like a place where you can really blossom and grow your program. I was talking to somebody earlier who was like, all the California RPM and health tech companies are really either direct to consumer or direct to employer because they can't figure out the intricacies of Medicare and Medicaid. The East Coast ones that come out of DC actually focus on Medicare and Medicaid. Because we know how it works. So there's a little bit of like a rift between the sort of digital health companies that are California based and that are like really trying to disrupt healthcare like a little bit differently. At least that's their ethos. And then you have those of us that like come from like managed care and like, you know, health policy, and we're like, we know how this works, and we finally have a mechanism to do tech stuff we've been wanting to do for a long time. And so the dragon has been unleashed from the DC crowd. So we count ourselves among them for sure. And that's why we're focused on Medicare. We also know that if you want to make a big difference or a dent in US healthcare spending, Medicare is where a lot of that sits. And so that's what gets me excited every day, which is, can this model, if it's scaled to hundreds of thousands of patients, at the end of the day, can it actually make a dent in Medicare spending? Can it make a dent in US healthcare, population health? And so those are the places that get me excited. My life dream is to be able to take this to Medicaid, so various state Medicaid programs where you have sort of the poorest and the sickest patients in the country. And you know, if we can prove that this works there too, that would make me very happy. It just depends on state level legislation and funding for RPM. So yeah, I hope that answers the questions. But fee-for-service payment is robust for this, and then value-based payment, ACOs that might generate shared savings, that's an even bigger incentive for them to potentially enroll these patients, or enroll their patients into a program like this. But well, time will tell what is effective and scalable.
Absolutely. So I think that's the time that we have for today. But Robert, any kind of parting words, you know, and especially to the student audience, you know, who might be listening right now, or who might be, you know, listening to the recording of this, and hopefully, you know, we did a good enough of a job. You know, if those maybe are interested in getting into the RPM space, you know, any parting words?
Oh gosh. So my parting words are, happy to talk to you offline with this. You can find me on LinkedIn, Robert L. Longyear, and you'll see Avenue on my site as well as Wanderly. And then you can follow me on Twitter at RL Longyear. I don't tweet very much, but sometimes I get all fired up about something and shoot off some tweets. So maybe I'll see you on there. My book, Innovating for Wellness, is on Amazon right now. It covers a lot of these topics. It's written for, you know, people who are just getting started and interested in policy and healthcare innovation. My next book is very technical. A lot of the stuff in this presentation is covered in depth in my next book, which will come out in August. It's called A Virtual Care Blueprint. And then let's see what else here. To the students that might be watching this, this is the future of healthcare. I studied healthcare management and policy at Georgetown. I was trained to run a hospital. And, you know, I learned very quickly that I wasn't interested in optimizing patient flow from emergency departments into the inpatient setting, because by that time it was too late, and was much more interested in improving health and improving like well-being and quality of life and happiness in the population. And at the end of the day, hospitals, if a patient ends up there and needs a procedure, the health system has not done a very good job keeping them healthy. So got very disillusioned with that. So my advice is, you know, you'll probably be recruited, or you'll go potentially work at a clinic or a hospital or a health system that thinks they're being super innovative. And at the end of the day, the model itself cannot really be that innovative, because if they innovate, they will potentially lose revenue. And so I'll tell you, go there, get the experience, learn how they work. I went to managed care on the payer side. I went to learn how that works, and then promptly leave and go someplace else that has the potential to really transform the patient experience. That's what I tell people. Go learn from them, go there, learn how they think, learn how they operate, learn where their shortfalls are, you know, learn how patients suffer when they go to the hospital, and then go out and find an organization that's trying to change things and make it a little bit better. But, you know, people all around are doing good things, but you know, the world's changing very quickly in healthcare, and digital will be a part of it across a number of different domains. So thank you, and keep Avenue in mind. I don't have any jobs right now, but hopefully we will shortly.
Sounds good. And we'll throw a lot of the links to, including Robert's book and, links to his companies, in our website as well. So please go ahead and check that out. So that wraps the session for today's, webinar for Transforming Digital Health webinar series. And, next week, March 23rd, or a couple of weeks from now, we'll be talking about the importance of using data in digital health. So please stay tuned for that and grab your seats through Eventbrite. And we'll see you next time.